looking forward to today's agenda. Before we get started, I wanted to let everybody know that we will be entering into executive session at the end of this meeting, and we will be adjourning from that executive session. We will not be reviewing and taking a motion to approve our minutes from our March 3rd meeting, and instead minutes from both today's meeting and March 3rd's meeting will be approved at our May meeting. So commissioners, we will have a chance to read two sets of minutes from March in the upcoming months, and we'll vote on them at that time. So I want to let everybody know who we are joined by, our commissioners. So let me read the participants on today's meeting. So myself, I'm Chair Valerie Sullivan. We have Bobby Kaplan, who's our Vice Chair. We have Designee Cassandra Roder. We have Designee Rebecca Butler. We have Adam Chapdelaine. We have Toby Choate. We have Christy Clenard. We have Tamara Davis. We have Jane Edmonds, Joe Gentile, Gerzina Gerard, Patty Jennings, Eileen McNamee, Melissa Murphy Rodriguez, and Tim Sullivan. So welcome, everybody. So at this time, I'd like to ask our Executive Director to take over the agenda and walk us through today's content.
Thank you, Madam Chair. Thank you, commissioners. Thank you, members of the public and staff for joining for this important meeting. We have a few items on the agenda today. We will start off with a wrap-up review of our engagement strategy, which we've had in place as an important part of our procurement process and will be ongoing in different ways as we head through the procurement. We will also, the second agenda item here, provide a pre-RFR overview of our strategy for the health plan procurement for coverage starting in fiscal year 24. And as the chair noted, we will have a brief executive session to close things up before we adjourn. Next slide. So just a brief review of our calendar for the remainder of calendar year 2022. As the chair noted, we do not have an April meeting, but we will meet in May to discuss, among other things, our procurement for the FSA flexible spending accounts. And then after annual enrollment is done, as we do every year, we will come back with a report on how that went and begin some of the discussions around our EAP procurement. We will come back again in the fall to pick up some of those same threads. Really the important critical aspects of our fall agenda, of course, are the votes that will come out of our review and recommendation of the health benefit procurement, and then also the pharmacy benefit. So we have a busy year ahead, a busy year over the summer to evaluate all of our bid responses, and then come back to you in the fall. Any questions on the calendar? Great. With that, I will turn it over to our Deputy Executive Director, Erica Schiavelli, for the engagement update.
Thanks, Matt. Good morning, commissioners. I plan to keep this very short so that we can get to the latter part of our presentation today, which is clearly our central focus. So as you recall, we began this very robust engagement strategy for this procurement about a year ago. And as a reminder, the purpose of the engagement was threefold, as you can see on this slide, which you have seen before. I'm pleased to report that we successfully completed the engagement strategy that we set out, and we were able to meet with the long list of folks that you see here. In the last few weeks and up until the RFR is released in April, we will be doing a last round of follow-ups, really to bring the engagement process to a close. I'm confident we accomplished what we set out to do, which is, from the previous slide, communicate clearly, collect feedback, and most importantly, build confidence in the procurement process itself as one that would be responsive and inclusive. Lastly, I want to thank all of the groups and individuals, including our very own commissioners with whom we met over the course of the last year, and who were very gracious with their time and their insights. And I'm happy to take any questions. Seeing none.
1 second.
Oh, sure.
See any either, Erica.
I see one from Commissioner Toby.
Toby's got his hand up. Hey, Toby.
Good morning. If possible, could you just kind of provide a snapshot of kind of the key themes you learned from the engagement? And I know those are different types of stakeholders, so maybe a little bit difficult to do, but I think that would be very helpful to kind of get a sense of that.
Sure. So this is, I tried to leave it pretty light on this slide because we did a little bit of that and I think the last meeting or the meeting before. We really, heard about concerns about affordability, behavioral health, and health equity, which are our three areas of focus. So what we did here was a lot of agreement with our assessment of where we ought to move forward. And so that was really helpful. The other thing that we heard was appreciation just for reaching out and making sure that everyone was included in the process. But overall, what we heard, like I said, was the affordability challenge was really the key focus of most of our meetings and all of the pieces that fit into that affordability challenge. So it was reassuring to hear that we were right on track with the direction in which we were going. And I would be happy to kind of give you a further list of details or a snapshot of a previous slide that kind of gets into additional detail about the themes that we heard.
I will say too that, we will touch on where appropriate throughout the presentation on the strategy, where we had kind of specific feedback that informed our strategy. So we will touch on that throughout.
Thank you for refreshing my memory.
And I just want to make a comment that I believe will resonate with everybody, and that's definition of affordability can change, and especially in the context of any changes that we may make as a result of what potential responses we get to our procurement outreach. So for example, we could discuss affordability in the context of confining access. And I do believe that may not be met with consistency of meeting our affordability challenge. So I know I'm speaking the obvious to so many of us, but I just want to make sure that we as a commission understand that if our members and constituents want affordability, there are trade-offs. Thank you. Hey, I see Jane also has her hand up. I hope you're not going to debate me, Jane.
I'm just curious. Just when I noticed it says Republican leaders' offices, why doesn't it say leaders' offices? Were Democrats not involved?
They were. The top in the purple box, legislature, says House and Senate leadership, and those would be the Democrats, as they are the leaders.
What's Republican leaders? What does that then?
That would be the minority leaders' offices. So just making sure that we met with both sides of the aisle. If it were reversed, it would be if the Republicans led the majority in the House and the Senate, it would just say House and Senate leadership, and then it would say Democratic leaders' offices. So just making sure that we get both to the majority and the minority offices.
Does that sit okay with you, Jane?
Yeah, it jumped out at me, just seeing it. So if I see it, it looks then redundant, is what you're telling me. In other words, when I saw the line Republican leaders' offices and knowing the importance of bipartisanship on an issue like this, I just wondered if Democrat leaders had also been met with.
Yes, of course. We met with the Speaker's office, we met with the Senate President's office, as well as House Ways and Means on both sides, and healthcare financing on both sides, among other committees as well.
Well, it certainly sounds like you were comprehensive in your approach, to the point where there's so much detail here that it raises questions. So good job on being as bipartisan as possible.
I'll take that. Thank you.
All right, let's move on. I don't see any other questions.
All right, great. So jump right into the main attraction for today. I'm pleased to present you with the pre-RFR release overview of our strategy for the health plan procurement for the 5-year contract cycle that begins in fiscal year 24. And just a brief reminder that the RFR for the medical benefit is slated for release a week from tomorrow on April 1st. Next slide. So as you know, the GIC team has been working with Willis Towers Watson for the last year to develop this RFR. And by now, you are very familiar with our priority areas: affordability, health equity, and behavioral health access. This slide also lays out, as we have done before, our guiding principles for the procurement, which we've also presented. And in addition to those listed here, we've talked for many years about meaningful choice for our members when it comes to health benefit options. So you won't see that concept explicitly noted here, but I want to assure you that it has continued to be fundamental about how we approach and think about this work. In its simplest form, the RFR is our mechanism to select our vendor partners. And that is, of course, very important given how heavily we rely on our health plans and PBMs to deliver coverage to our members. However, there are other objectives within the RFR, which I want to note, and some objectives that we can make progress on outside of the RFR. So within the RFR, we want to gather information to evaluate obstacles and opportunities to making progress on these priorities, and get a better understanding from bidders about how we can develop the best strategy over the months ahead. We also want to explore changes that we can make to the features of our plan design, which we will do on a slightly different timeline as we typically do. A different timeline from the RFR, but our normal timeline of reviewing plan design early in 2023. But we also want to leave room throughout this process for complementary strategies that we may need to employ during the 5-year window. So we can gather information on what those strategies may be. Similarly, as I said, outside of the RFR, there are other aspects that are all part of the work and decisions that we will make leading up to July 1st, 2023. The RFR is hugely important, but everything that we do doesn't necessarily fall within the RFR. And I'll touch on a few of these throughout the presentation. Next slide. All right, so throughout the last year, the strategy team has brainstormed and researched a wide array of strategies that align with these guiding principles. We've explored and evaluated a number of them. We've sought feedback from stakeholders throughout the process to inform our evaluation through that engagement process that we discussed. And we are also very mindful throughout this process of the findings of our member preferences survey. We then moved on to prioritize a narrower set of strategies for further development, leaving aside some putting others on a longer timeline so that we could evaluate them further. You'll see those separated out in the columns here. I'll touch on several of these in more detail in subsequent slides, but I do want to touch on a few that you see here today. So under long-term strategy separate from the RFR, you'll note clinical condition point solutions and centers of excellence. These are two areas where we don't take directions in the procurement, but we'll evaluate those over the 5-year period. So here, let me say that, we rely on our carriers to have effective utilization management, care management, and in some cases, centers of excellence solutions so that we can effectively manage coverage for high prevalence conditions and high cost conditions. Among these, diabetes, hypertension, cancer, musculoskeletal conditions. So we rely on the carriers for those programs, but we also want to preserve the option of carving some of those out from the carriers if we judge that we can benefit from a different, more unified solution within the GIC. So in the RFR, we will evaluate the carriers' approaches to these programs, but we do leave ourselves room to take a different approach if that proves to be necessary. You'll see in the second column from the right, under market developments that we will monitor for future consideration, payment and delivery system reform. So here's an area where through our engagement strategy, we spent a good deal of time exploring innovations that are emerging in the healthcare market. We've found that there are some really interesting new models being put in place by Mass Health and Medicare around accountable care, which hold a lot of promise for us to potentially support our members and deliver better coordinated care. And we will look for ways to support that reform through the RFR, but the state of those reforms, in our judgment, is really still developing. And in our view, was not quite ripe for the GIC to make them a centerpiece of our strategy. We will, however, have a number of questions for carriers also about how they're managing medical drugs. You'll see this on the left-hand side where we are addressing it in the RFR. So medical drugs, these are drugs typically administered in a clinical setting, rather than being something you would go to the pharmacy to pick up. So those drugs would be on the pharmacy benefit. These are covered by our health plans and often very expensive drugs. So we will be very clear in the RFR that we are requiring 100% of the rebates for these drugs to be passed through to the GIC. Commissioners will recall that this issue came up as part of our audits of our carriers, where we had some variation there about how much of those rebates came back to us. So we want to resolve that and make that clear. We'll also be pressing carriers for new strategies to ensure that these drugs are administered in the lowest cost setting where that's appropriate. We have seen through our research and engagement that there are oftentimes tremendous markups for some of these drugs when they're administered in a hospital setting. And we and many other health plan sponsors are exploring different ways to do that more effectively and less costly. So I'll stop there with this slide. As I said, I'll be touching more on some of the other items throughout the deck, but I'm happy to stop for a question if there are any.
Matt, I don't see any.
Okay.
I've got Eileen's hand up. So hi, Eileen.
Hey, how are you? Good morning, everyone. So I did just want to say, I think as we think about affordability, care coordination is going to be extremely important, particularly for those with chronic conditions, especially as we think about the backdrop of inflation that we're facing. So just want to make sure we keep a focus, excuse me, on that.
I couldn't agree more. Definitely concerned about how do we strike a balance between care coordination and reducing costs. So nice comment. Anyone else? Questions?
I would
Bobby,
say just, I'm sorry, go ahead.
no, Bobby has a question, and then potentially you could address both in the context of this slide.
Yep.
Hi,
So,
Bobby.
hi, good morning, everyone. I have a question that's sort of related to Eileen's, which, regarding inflation, right? We're going to be entering into a, three-year contract, right? With 2 options to renew, right? 2 one-year options. So, considering inflation, like how do we sort of, it could be much higher or, suddenly it could drop, right? And so I'm very curious how that will be addressed, because we're looking at, long-term, quite a few years ahead. And I'm very curious how that, and would we be able to adjust down, let's say, depending on what happens with the market and the economy?
Yeah, great question, Bobby. I would say that's actually a topic I want to spend a little bit more time on in a subsequent slide. So if you're okay with that, we'll discuss that in a little bit.
Sure.
I will say, just to Eileen's point, one of the dynamics that we see across different categories of service and clinical conditions is the site of care. And I mentioned that as it relates to medical drugs, because those are often delivered in very expensive settings, and in many cases they don't need to be. But I think we see that across a number of different types of services. So it's those care management and utilization management programs that are really essential to make sure that we're delivering care in that least expensive setting. But also for the chronic conditions, as you mentioned, we'll be looking for carrier responses to those that are really robust.
Does that answer your question, Bobby and Eileen? Both of you had questions?
It does. Thank you.
I just wanted to see if you could just make a brief comment on why high deductible health plans were eliminated as a priority.
That actually will come up in slide 5. So we will get to that momentarily.
Let's put a pin in it and keep
Yep.
moving. Thanks.
So before we get to the plan design and plan types, such as high deductible health plans, I want to talk briefly about our vendor portfolio. I know this is probably on many of your minds. As I've mentioned in the previous slides, we are very focused on creating meaningful choice for our members. That continues to be an important focus. And they have wide choice when it comes to vendors today. We currently have 6 health plan vendors. But I also want to note here that consolidation of this current carrier portfolio is not an intentional strategic aim of this procurement, as it was in some respects in the last. In our judgment, there is limited bang for the buck in taking our vendor portfolio in a new, dramatically different direction, particularly when evaluated next to the kind of disruption that it could cause to our members. That being said, it's important to make a few things clear at this point. Not all current carriers may choose to bid. So, in fact, we expect that only 4 of our 6 current carriers will do so. We know that Harvard Pilgrim and Tufts, through their merger, will be submitting a unified offering through the GIC. And Fallon, as we know, has already made the choice to exit the commercial market for our coming fiscal year, which includes the GIC. So I think it's important also to note that it's possible, even likely, that new non-incumbent plans will bid, and we may find that they demonstrate real value. And it clearly would not be wise for us to explicitly state at this stage that all incumbents are guaranteed to be selected. It is possible that we may decide, based on the bid responses, that one or more of our incumbents have not submitted a bid that is acceptable and that gives us the confidence that they can perform as we need them to perform. So just to be clear, this is not an outcome that we're intentionally driving toward, but the procurement process will only be successful if we, if we follow the process and we don't concede a place for all incumbents before evaluating their bid responses. So that's what I wanted to say about the vendor portfolio. Next, I want to talk about the plan portfolio, but I'll pause there if there are comments or questions.
So Christy has a question. Go ahead, Christy.
Thank you. Can you just talk a little bit more about, because I think you're right that the last procurement was very focused on consolidation. And so I hear you that you all have decided that any benefit from consolidation isn't as, there's no bang for the buck, I think you said, and that the impact to the members, kind of that concern outweighs any benefit. But could you just talk a little bit more about why you all decided not to pursue that strategy?
Yeah, well, I will say there are some, it's a cost benefit analysis, right? It's in our case sort of an impact benefit analysis in many respects. So we have 6 plans. They are all highly rated plans, among the most highly rated in the country. The functions they perform for the GIC are all fairly consistent. They do so, to varying degrees of effectiveness around member services, around provider network development. But there is not there's not wide variation among the vendors that we choose or that we have today. And there is, so that would be one reason to consolidate, one rationale for that. I would say working with fewer vendors for us just on an administrative level produces some efficiencies. But I think the core opportunity in consolidating carriers would be an assessment that rather than having 6 carriers negotiating with providers based on their slices of our membership, that we might better position a fewer number of carriers to change that negotiating dynamic and ultimately get us better provider prices. And I think our evaluation is that the upside on that last element is really not that high, that we have, if you look at the health insurance marketplace here today, we have at least one carrier that is substantially larger than any of the carriers that we work with. And even they, with their significantly larger size, aren't able to produce the kind of change in that dynamic with providers that one might hope. So we, were we to go the direction of consolidating into one carrier, for instance, as the extreme example, Our view is that it would provide very marginal increased leverage for that carrier vis-a-vis providers. And when you weigh that up against the disruption to our members and how much they value the choice that they have today, that's where the limited bang for the buck comes into play. And I think we felt that we're better served by looking in other directions. I hope that's helpful.
I do
Yes,
think,
thank you.
and for me, I think it's also helpful too. So I may be speaking for a couple of commissioners, but let's hear from others. So Eileen, I see your hand is up.
Yeah, thank you. So Matt, what you said does make sense, but I do remember the conversation from the last procurement where it really was about, so if we can't kind of consolidate all of our business into one carrier in a way that influences, prices for our members, I think the opportunity is with different benefit design so that there's actually a choice in the type of insurance that they get, irrespective of the carrier that provides it, but what type of health insurance they're actually purchasing. So I'm just wondering what we're going to do to make sure that we encourage kind of different benefit design.
Yep, and that's
creative benefit design.
And that's a great segue to our next slide, where we'll talk specifically about that. So product portfolio, thank you for that, Eileen. Smooth transition. Sorry, give me just a moment. So in addition to broad choice among vendors, the GIC also has a tradition of a variety of plan types. And we note them here in the lower left. We have broad network POS plans, we have narrow and regional network HMOs, we have an indemnity plan, all for the active side, and Medicare Advantage and Medicare Supplement plans for our retirees. There aren't a plethora of other plan types out there that we don't currently offer. But as part of our due diligence, we did want to make sure that we thought that through. So one plan type that is not uncommon in the commercial market is high deductible health plans. Madam Chair, you asked me about that. Often paired with a health savings account. So these are governed by federal regulations. We have evaluated this possibility and have decided at this time not to proceed with the introduction of such a plan. And let me say a few words about that. I think first of all, our member survey shows that our members are highly sensitive to changes and increases in cost sharing, which by their very nature, this would do. This type of plan would, that's what it's designed for. Through our engagements, we heard consistently about concern about high deductible health plans. I would say for the GIC as well, implementing such a plan with a health savings account would be a substantial undertaking for us, particularly if an HSA were to be funded even partly by the Commonwealth. That would require some statutory adjustments in order to do that. But I would say also there's a concern that consumers in these plans don't always respond to the financial incentives in them in the way that we would like. In many cases, they avoid unnecessary care. They avoid not unnecessary care, but actually necessary and valuable care, which can lead to poor health outcomes for them and ultimately greater costs. We do have Dr. Jeff Levenshires from Willis Towers Watson on hand. He can speak to some of the literature that we've reviewed as it relates to these plans. But in the end, I think our evaluation of kind of member wariness or interest in these plans, we weigh the substantial lift on our part and then just not achieving the outcomes that we would want to see for our members is where we landed on the high deductible health plans. Jeff, can you just say a word or two about what the literature says about these plans?
Sure. Thanks, Matt. So what researchers have found looking at very large databases is that when people move to high deductible health plans, they, as Matt says, they edit out both low value care, which is good, and also high value care. So it's nice when people don't get an MRI 3 days after they hurt their knee skiing, but it's bad when people don't go to the eye doctor and therefore they let their diabetic eye disease get worse and they end up blind prematurely. A lot of the research has been done on an Optum database, which it's like 50 million people, so it's pretty large and good. A lot of it's been done by a Harvard researcher who recently moved to Duke, Frank Wareham. What he's shown is that women get later mammograms, later breast biopsies, and later chemotherapy for breast cancer when they're on high deductible health plans, and that's interesting also because we all expected that would be true in low-income communities, but it's actually true even for women who live in high-income zip codes. He also showed similar findings with diabetic eye disease, where people on high deductible health plans tended to wait longer and have later treatment, which likely leads to more blindness. Although this was a claim study, so he wasn't able to show that. Out in the world of employers, about 20% of the employers who had gone to full replacement high deductible health plans moved back to at least offering a non-high deductible, over the last 4 or 5 years. But as Matt said, these are very common. These are very common, out in the private employer world. In addition, in most instances, private employers would fund plans based on a constant dollar rather than a constant percent, which is what is required for the GIC. So it would be substantially harder for the GIC to create a really attractive high deductible health plan because the premium would be based on a percentage of the cost, which would be much lower rather than absolute dollar, which would allow for somewhat more funding. I think I said more words than I should have.
Well, that was very helpful.
That's good, Jeff.
I don't see any questions, so you've answered all's are, and we can move on.
Thank you. And just actually the second bullet under the FY24 procurement box here also speaks to how we're thinking about this, because one can certainly say that a high deductible health plan, the reservations aside that we've already referenced, do engage members when they're choosing a service to choose a lower cost service, right? The financial incentives are there for that. And that is a dynamic that we do want to utilize, right? But not within the high deductible health plan type. So what we do want to do, though, is explore innovations and features of the existing plans that we have, our narrow network plans, our broad network plans, and the tiering methodologies that we put in place for them to have that kind of incentive for consumers to choose high value, low cost care. So we want to hear from providers through the RFR about their next generation strategies around provider networks. Are there ways that we can structure a narrow network plan that can make it more attractive to GIC members and have them really take another look, because we really have leveled out at about 25% of our membership in those plans. We want to review, and we are actively reviewing our tiering methodologies, because as we've spoken about that in the past, our members have not responded to those plan features in the way that we would like. and the way they're intended. So again, we will use the RFR to learn more about this, and those are the sorts of changes that we would make through our plans as we get into early 2023 after the procurement, when we discuss plan design. I would say here we're also learning, I mentioned earlier about accountable care organizations on the public side of the insurance market, but we're also hearing some really promising and creative new ways in which carriers and providers are working together. Some of them, including some of our carriers, are integrated within a health system. Others are working in partnership in creative ways with providers as separate organizations. So we are providing plenty of room in the RFR for us to hear about these new innovations with the hope of being able to bring them to our members. I mentioned that.
Do you have another question, Eileen?
I do. So it was more a comment, and Matt, you just mentioned the tiered networks, but thinking about it, to me, I do feel like we need to kind of take another look at that, or just try to encourage those types of plans. I understand people shy away from narrow networks. They're concerned they're going to want to see a specialist or have a procedure at a certain place and be unable to do so with that product. But I feel like tiering is going to be critically important if we're stressing value and if we're trying to get at some of the price variation. And again, just, not to repeat myself, but I do think with the inflation background to all of this, I think we're going to see some spikes in prices, and it's going to be really important that people kind of understand price differentials and we try to incent going to value-based providers and so forth. So I do think a fresh look at tiering is important.
Yeah, and I will say, what was I going to say? You just triggered a thought and it went out of my head. No, it'll come to me.
All right, well, let's keep moving and it may come to you. Thank you for everyone who's making comments so far.
Must have said something funny.
Yeah.
It did just come to me. Whoever's laughing, it prompted it for me. So one of the things that we are doing as well, we have done and will continue to do through our review of the responses, is looking at comparable benchmarks around cost sharing. So in this case, Eileen, you I'm sure know more about this perhaps than I do, but on the private employer side, God, it just went right out of my head again. I apologize. That contribution to premium. So different employers can vary the percentage that they contribute to premium for different kinds of plans to sharpen the financial difference between a high value plan and a lower value plan. We at the GIC do not have that flexibility. Those contribution amounts are they're negotiated in the legislature essentially and live in state statute. So our ability to sharpen the incentives for these high value plans does come down to adjustments in cost sharing. And that is where we're talking about copays, deductibles, and tiering methodologies. So this is really where we want to spend a good chunk of our time to try to drive our members to the lower value, to the higher value, lower cost plans.
Christy, you have your hand up. Should we move on after Christy's question rather? Go ahead.
Matt, have you guys thought at all about, again, trying to incentivize people's behavior? I get my health insurance through my husband's company, and one thing we have to do every year is a health questionnaire, some biometric screening, and what it gets us is a pretty substantial cut on our share of the premium. Has there been any, I feel like in the back of my mind, I remember there being a talk many years ago about tobacco use, that resulting in some kind of, difference in cost sharing. Has there been any thought about doing something like that?
Well, that may be an area where we can explore and get feedback from the carriers about those kind of features those kinds of programs that they're offering to other plan sponsors. I think the discounts on the premium become complicated for us because of what I mentioned, which is that the contribution amounts from the employer, in this case for our state employees anyway, being the Commonwealth, those are not things that we can vary. I am familiar with, on the private side, I've been in one of these plans before where you have a health reimbursement arrangement, and going through that sort of a health screening, those sorts of things are incentivized. You can get a larger contribution from your employer to the health reimbursement arrangement. So we will evaluate those. I'd say some of the ways in which the GIC is unique, some of them I've mentioned here, make those difficult and complicated for us, but we do want to evaluate those kind of strategies.
Well, that is good to hear. And to Christy's point, you may not need to give a discount on premium, but there could be some tchotchkes that are given out if people do engage in a healthcare survey. It just helps to educate our constituents, create the awareness, and let them know that they do have the power to take care of themselves, and they already do. Let's move them along so that potentially they feel, more empowered to make decisions that sometimes are good for their healthcare and may save money. So,
yeah, it's an excellent comment, Christy. We will take that back and take a look at the RFR to see if there's ways that we might be able to incorporate something more in that way.
I don't see any other questions, so you can keep going.
Okay. So we will challenge the plans for innovative solutions. We will explore the types of changes to network and plan design that we've just been talking about. But as both Eileen and Bobby have mentioned, spending growth is a challenge for us. And in each of the last 2 years, we've had spending growth near or above 5%. And frankly, I share the concerns that this trend may accelerate. So it's essential for us at the GIC to clearly articulate how we define affordability for our members and taxpayers who combined foot the bill. So how can we do that? When the legislature enacted Chapter 224 of the Acts of 2012, they established an affordability target for all-in spending on healthcare in the state. And that was the Commonwealth essentially putting a line in the sand to say that growth in healthcare spending may not grow faster than the overall state economy. And if it does, we need to make adjustments in how we pay for and deliver care. So the rationale here, of course, is we need to get away from healthcare spending that over time gradually erodes and takes a greater share of the state's economy and inhibits investment in other important areas of need. Of course, those consequences are substantial. When that happens, we depress wage growth for workers. We raise costs for businesses in Massachusetts, making it harder for them to compete globally and nationally. They consume an increasing share of the state budget, leaving fewer resources for important priorities of education, transportation, housing, and others. And at the GIC, a rule of thumb that we are very aware of is that every 1% increase in our budget is approximately a 25% additional obligation for the general fund. So it makes it harder and harder for the GIC with these growth trends to continue to provide the kind of generous benefits to our members that they have grown accustomed to and they deserve. So I and others look at these trends and feel that it's not sustainable, and we know that we need to do better. So, but what does better look like? For starters, we can, and through the RFR, are establishing an explicit goal that aligns with Chapter 224, that our costs won't grow faster than the state's healthcare cost growth benchmark. And we're going to set ourselves on a path to get there within 3 years. So just a little bit on the benchmark for this year, as I suspect many of you will be aware, it's 3.1%. The Health Policy Commission is in the process of determining that number for 2023, and they do have flexibility within the statute to adjust that up or down. So we have our work cut out for us, and this isn't going to happen overnight. So in the RFR, bidders will be challenged to present a detailed set of strategies to get us there. And responses from carriers will be judged based on who we have the most confidence that have the most innovative and robust strategies to meet that objective. Additionally, at the GIC, we will use all the tools at our disposal to accomplish this goal. We will closely monitor our carriers' progress starting on day one, using a variety of performance metrics that are directly linked to their proposed plans. Things like total cost of care relative to the benchmark, unit prices negotiated with provider systems. We know that continues to be a big piece of the puzzle. As I mentioned before, shifting care away from the most expensive settings to less expensive settings, and strategies like centers of excellence and addressing medical drugs through site of administration. So we expect to hear from carriers a variety of strategies on all these dimensions, and we will monitor how well they implement their plan and help us to meet that objective. I think it's important also to note here that we will hold carriers accountable for that performance. We are developing a refresh of our performance guarantees with carriers that put them at risk for real financial consequences for not performing well. As we have and will do as necessary, we will put together corrective action plans, work with them to put together corrective action plans where necessary. And as we have in the past, if we have a plan that's not performing well, we have the option to freeze enrollment. And as Bobby correctly noted earlier, we have contracts with plans set up in the RFR for a 3-year term with 2 one-year optional renewals. So it is possible also that if a carrier persists in not performing to help us meet that affordability objective, we may not renew them after year 3. So we if we think we can do better also than the carriers do, as I mentioned earlier, around care management, utilization management, centers of excellence programs, negotiating good rates, maybe some of these are some of the functions that we take back from the carriers. At the same time, though, we will, through the RFR, solicit suggestions and ideas from carriers on steps that the GIC can take or needs to take to position them to help us achieve this goal. So what we've set up here, I think, is a flexible framework. We will evaluate throughout this process whether new tools may be necessary for us. The healthcare marketplace right now is a really dynamic place. We have new models emerging in the marketplace, some of which I mentioned earlier. We have a renewed interest on the part of some for a more robust role for government intervention here. And for us, the health benefit procurement is an opportunity to learn more about what this all means for our members, and also to leave room for us to adjust course as necessary to meet the objective that we set out for ourselves. So it's an ambitious undertaking. We think it's time for this sort of a framework. It's, like I said, it's not going to happen overnight, but we think we have the right framework to get there. So that's a lot of talking on one slide. This is really, I think, the centerpiece of the affordability agenda. So I think what I might do is just, if we can touch on the next slide, and then I'll pause for questions. The next slide is just a brief reference. So here you'll note some, these are the specific domains, among the specific domains that we really want to press carriers on. I've touched on many of them already. You have some that are the more traditional tools like administrative fees, provider discounts, care management programs. But we also want to press on some that are a little more emerging, like digital engagement, the use of data analytics, and new strategies to manage high-cost drugs that are on the medical benefit. So I'll pause there. Happy to take questions on the affordability framework before we move on to behavioral health and health equity.
So I see Toby has his hand up, and then Bobby. ahead, Toby.
Matt, on the affordability framework and the innovation bucket, what is your judgment? I mean, the current carriers, we're probably going to have 4 carriers, and when this is all over. And what's the level of innovation that's going on with them right now? Because if they're not innovative now, it's not going to make any difference to us. You just don't wake up to a procurement and say, I'm going to be innovative. You know these people, we do business with them. What's your judgment on their level of innovation?
It's a great question. I'm optimistic that we will see creative responses. I really am. Will they be universally creative across the bidders? I suspect not. But as I said, there are new models that are being worked on, and they're being debated in the public sphere today, right? We have one provider system that's exploring expansions in a variety of areas, but with the promise of increased affordability in the long run. And I think the GIC is really uniquely positioned, I think, to put those to the test. And the RFR will be our opportunity to secure commitments from a variety of carriers to prove the value of their models. I will say on the digital engagement side, I think, again, that's an area where I'm really optimistic. I think relatedly with, the emergence of telemedicine, telehealth, virtual care, there are extensions of those strategies that, through other digital tools hold some real promise. And I think, I think where it may be more of a challenge is for them on the provider network side, but we've heard some interesting ideas, and but as you note, Toby, the proof will be in the pudding, right? And if after we review those bid responses, we are underwhelmed, then we've left ourselves room in the way that we've crafted the RFR to take a different path over the course of the 5-year period. So we will not be, setting ourselves up to be in a position of simply taking what they have to offer. And if it's not impressive, we shrug. I think we're ready to pivot and do new things. I think the thing that I would emphasize here, which I've touched on a couple times, is the RFR and the procurement is a really important opportunity to drive change, but it's not the only one. And so we will watch all that very closely.
I think your approach makes sense. Thank you.
Thanks, Toby.
Go ahead, Bobby.
Yes, I have a question regarding if we can go back to accountability. So it's very important to have the data somewhere between years 2 and 3, right? So that we know how they're performing and if they're in compliance with a contract, because in years past, it seems to me that we have just automatically renewed with, very little information, certainly not a lot of data. And I think that we really need to make sure that, these renewals are not automatic, that we have looked at sort of every piece of the contract, particularly when it comes to accountability, and whether they are not only performing in that way, but performing as far as providing care. And so I think it's, so I'd like to know sort of what the plan is, for that period. Are we going to be gathering data all the way along and then have some sort of report or audit done in that period so we can, make smart decisions about renewing and not just, sign off on it?
Yeah, it's a really good point, Bobby. And I hope that those our vendors and others who are listening in hear very clearly that we are really going to lean into monitoring our carrier performance. That said, we do that today, right? Our teams are literally weekly and bi-weekly calls with all of our carriers. They monitor their performance. They identify problematic trends and delve into them with our carriers. So this is ongoing daily work of our vendor management team under Jim Rust's leadership, and with other members of the senior team. So I can assure you that the plans that they put together will be translated into a variety of very specific performance metrics that we will monitor from day one. Certainly we are establishing year 3 as an important goal, as an important milestone for reaching that affordability goal. And we will use all of our observation and monitoring of our carriers throughout that 3-year period to make the determination of whether it's in our interest to continue on with a vendor that is not performing well. So that is the message that I want to be sending loud and clear here, that those 1-year optional renewals, they're going to have to work for them. And they're not a given.
Yeah.
Good. I'm glad to hear that.
Yeah, a great question, Bobby. And, you know, Matt and team, and maybe Jim, potentially coming up with some sort of scorecard on how you're holding the vendors accountable and providing that at, you know, quarterly timeframes to us as commissioners might be a good way to put your comments into practice and be at the forefront of letting vendors know that we would like them to be data oriented in showing us. So thanks for that, Bobby. I see Eileen has a question, and then Christy, do you have a follow-up question?
But before we do that, can I just add one other brief coda to my prior comment here, which is, you know, we've talked a lot about provider prices and those negotiated between the carriers and providers. We will also be insisting on greater line of sight into those dynamics as part of our monitoring of carrier performance. We know that's an important variable here. And I think in the past, we've had more high-level strategies, but we're going to have a greater line of sight into those dynamics as well.
Go ahead, Eileen.
Thanks. So Matt, I just wanted to applaud you for the strategy and say for some of us who've been around and actively involved in passing Chapter 58 and Chapter 224, you know, it's important just to note that the benchmark is about cost growth. And there were many of us at the time that were saying we had to take cost out of the system because we were spending an awful lot of money on healthcare. And so it's just important to point out, this is about growth year over year, and it's not about really taking cost out of the system. And I know, and I think we're being very reasonable given a 3-year phase-in, because really affordability has been the goal and the unfinished business of Chapter 8, and we're coming on 14 years since it was passed. So I think without some kind of line in the sand, we'll never get there. So I do appreciate this approach.
Thank you.
Christy, go ahead.
Thanks, Valerie. The one thing I agree with everything about the pressure on the vendors, but it seems to me too that some of the ways it's going to require our members probably to maybe do things a little differently than they're used to, because that's what the vendors are being, to some extent, being measured against. So someone who's used to getting, for example, medical drugs in a hospital, if I'm hearing you right, is now going to be required to get it somewhere else, or have a lot of pressure put on that member, because that's what the carrier is being held against for that shift, for the cost to go down. So I agree, a lot is on the vendors, but I think this is also potentially, it's going to ask a lot of our members as well.
That's a really good point, and thank you for raising it. I think that is absolutely true. And we have taken very seriously the feedback we've gotten from our members and those that represent them about the importance of choice. And you'll see in this strategy, as I've already said, that we want to preserve a good measure of that choice. But it does increase our expectation that adjustments to our current plan designs, our current vendors, our current plan types will be meaningful. and they will have to be meaningful. So there will be ways in which our members are going to need to adjust to changes in their plans. But that's the only way that we can make progress here. If we're using our current vendors, our existing and some sharper tools, and over time, if that doesn't prove sufficient, even changes to member incentives, I think we need to be open as a commission to going in different directions. And I am certainly open to that. I don't want to find us at the end of 3 years not meeting our objectives and not having consequences and not being able to adjust course.
Well, I think this is good discussion. I appreciate commissioners weighing in. I know it's tough on Zoom, but this is important stuff, and we need to hear from the commissioners feedback on this, because it sounds like in a week it's going up to our vendors. So we need to register what we want to see in this next procurement, and I appreciate people stepping up and talking, even though it's so hard on Zoom. We've got some engaged commissioners here, so good stuff. All right, keep going, Matt.
So just before we get into behavioral health, there was one other aspect of our plan portfolio. If we can just jump back to the product portfolio slide, which I think, what I neglected to mention here or to particularly call out was new options for our members who live out of area. So we have about 15% of our members, largely retirees, but not only retirees, who live outside of the New England area. They include retirees on Medicare plans, but also a significant number of members who are not eligible for Medicare plans and who enroll rather in our active plans. And there, while we do have broad choice broadly for our members, some of our members have very few, and in some cases just one choice. So if you live in Florida, for instance, and you're on an active plan, you only have access to a Unicare plan. If you're in Medicare, you have several options for Medicare supplement plans, but the Medicare supplement plans are all, as they're federally regulated, quite consistent. We only have one Medicare Advantage plan, but it's only available for those in area. So we do want to explore the possibility and are inviting bidders to provide some options for those members that live out of area. So I didn't want to miss the opportunity to mention that. All right. Of course, behavioral health, a high priority for the GIC. And here we will also be raising the bar for our carriers to do more. We've talked a good deal as a commission about the importance of making sure that payment rates for behavioral health are sufficient and at least not comparing unfavorably to what public programs like Mass Health pay. But we also will be requiring our carriers to submit detailed plans with tangible targets. And again, we'll hold them accountable over time to implement those plans. So what are the sorts of things that we're looking for? So detailed analysis of members' usage of out-of-network providers, which we know is substantial in the behavioral health space. We've talked about that in the out-of-pocket report discussions. We want to set clear expectations that they contract with new provider models that are coming online with the implementation of the behavioral health roadmap. We will be demanding thoughtful approaches to substance use disorder treatment, including partnerships with external entities if that's necessary to really make progress in this area. So we need to treat this as the real crisis that it is and that we've called it by setting very high expectations on the carriers to expand access for behavioral health. I will say outside of the RFR, the GIC is entering into an agreement with Commonwealth Medicine. This is an organization affiliated with UMass Medical School. And they're going to help us in the implementation of these roadmap features, increase capacity at multiple service levels. This is an organization that actually worked closely with the Executive Office of Health and Human Services on the roadmap, so they are uniquely positioned to assist us in this work. And we're also seeking their assistance to make sure that beyond the roadmap, we are conducting a thorough mental health parity review to make sure that we're compliant with state and federal mental health parity standards. We've done a good deal of work on this over the last several years, but we want to lean into this a little bit more. So on behavioral health, I'm happy to pause for questions or thoughts on that.
Go ahead, Bobby.
So regarding behavioral health, this includes sort of getting information about what their approach is to for outreach to new providers, like to encourage providers to be in, sort of our network, right? Because that's always a complaint, right? Is that there are not enough mental health providers, or there aren't enough who take insurance, who accept insurance. And so I'd like to know if we can get that data, regarding their outreach, strategies, right? Because I think it's really important to get that information, because people are on long wait lists for just regular services. I don't mean for beds. That's a whole other issue.
Yep.
But so that we have some idea as to what they're doing or trying to do in that regard.
Yeah, it's a great point, Bobby. And I would, the access problem for behavioral health services, we know that there are gaps in certain categories of service where the capacity simply doesn't exist to meet the need. I think child psychiatry is one example. So there's, bringing new providers into network will only get you so far. Even if you have all of the providers in network, there still aren't enough of them. So that's a global challenge for the Commonwealth that we can participate in, but we can't solve it on our own. But I think what you're suggesting kind of goes back to what I mentioned about out-of-network usage. We have had some interesting recent discussions with one of our carriers. I'll pat them on the back by naming them because I think it's worth doing. Unicare through Beacon, that has done some really thorough evaluation, as I said, of those providers where there's high out-of-network volume. They're not in network, but a lot of members go there and pay out of their own pocket. They've also done analysis geographically to see where there are specific gaps, because it's not uniform across the state. There are areas where it's more of a problem. And, they're developing strategies to get those specific providers into network and finding out what it's going to take. And so that's the sort of thing that we want all of our carriers doing. That sort of detailed analysis and real concrete strategies. And I will say, the GIC has a role here, right? If we find that there are providers in the state that are broadly out of network with all of our carriers, I suspect we'll find that there's overlap here. We want to work with our providers to try to get them into network. So I think there's a lot that we can do here. And a lot of it can be sort of data-driven and analytics-driven. I hope that's helpful in answering your question.
Yes, thank you very much.
Let's keep moving along. I think we're a little bit behind on agenda. Go ahead, Matt.
Sorry, had myself on mute. So health equity, clearly also a top priority that we've talked a great deal about in our prior meetings. Here, we will similarly be setting high expectations for comprehensive approaches from our carriers to deal with health disparities. We've discussed prior the broad need for data standards. This work is already underway across state government. We are participating in that. Our carriers are participating in those discussions. And we will demand a commitment from carriers to continue to work in a collaborative fashion in good faith to create those data standards. Without those, we're flying blind in many areas of health disparities, and we need that as an important roadmap to do better here. But we also know that we can't wait for data standards to emerge to take action. So thankfully, we have seen lots of really promising work among our carriers to take these concrete near-term measures. And we'll be expecting them to present some compelling strategies through the procurement. I think thankfully here, there is a lot of work that's happening even just outside of our carriers that we can leverage. NCQA, which is a national accrediting organization for quality, particularly focused on quality of care and coverage. They've created a new health equity accreditation program, which we've heard about from several of our carriers who are pursuing that accreditation. So that's an area where I think there's really specific outcomes that we can leverage. I think also here, the role of federally qualified health centers is really important. These are federally regulated, federally funded community and neighborhood health centers. They are locally governed. There are requirements that their board be made up of more than half of people from the community that are being served, actual consumers of their services. And they have a long history of delivering comprehensive, culturally informed primary care in underserved communities, addressing social determinants of health. They've been doing this for decades, long before patient-centered medical home and other similar types of models have emerged. So we want to look at carrier networks as they relate to federally qualified health centers and make sure that we're providing this value option to people to meet their needs. So lots to do here in the health equity space. And we're encouraged about where we can lean into this more. I'll pause for questions there.
And I think we need data, though. And so I know you know this. It's how quickly can the health plans provide that to us? How high quality will the data be? So I applaud the effort. We're all supportive of it. And we just need to keep pushing on the carriers to push on their providers to get us the data. So good stuff. speaking the obvious, I know. I don't see any other questions, so, oh, I see Bobby. Go ahead.
Thank you. I'm very interested in what the standards are for health equity accreditation. And if we could possibly get some more information on that, I would appreciate that, because I would like to know what the criteria are, and how we can ensure that that the providers, right, the carriers have contract with providers who meet those standards. Maybe not this year, that's going to happen, but I would like to know and monitor its progress.
Yep, we're happy to provide more information about that to you and follow up to this meeting. I think I was very encouraged to hear about that initiative from NCQA. I think there's also really great work that's being done at the Health Policy Commission as part of their health equity agenda in the area of maternal and child health. There's a lot of work being done by some really thoughtful people that we can leverage here.
Jane has a question too, so go ahead, Jane.
The question is related to Bobby's. I'm trying to, if you could say more about how you're going to measure commitment. Very often there are a lot of good things that are done, but at the end of the day, it's very hard to see the results. And it's really hard also to see the progress. And as Bobby suggests, it might take time, but I think it's important that we have a capacity to honestly see that demonstrated commitment, other than words, other than scattered programming, which may be wonderful in their own right, but overall may not deliver the kind of results that should be seen, given the situation that we're currently in, which is a very challenging one for everyone.
Yeah. So go ahead, Margaret. This is your
how you measure that commitment, so that it's not just platitudes and statements and the like. And 5 years from now, we're having the same conversation.
Yeah, great question. I think we have Margaret Anschutz has been leading this work on Jim's team, who can speak to that.
Thank you for that question. It's very important. I think I've said prior, I really want to see that the carriers are operationalizing their commitment to health equity. And what does that mean? Take an example with maternal health. We know there are national disparities in maternal health. We don't have all of the race ethnicity data on our membership, but we are working towards that. So as we work towards getting the data in, we are not using the fact that we don't have full data as an excuse not to push on improving maternal health care, for example. So we are going to be looking more closely at prenatal care, postnatal care, C-sections, and then maternal health specifically. While we're getting the data in, we have a couple sources where we expect the data to come from. The carriers are collecting the data as well. Talking with the carriers, I can think of one in particular that is out in front of the other carriers. They have brought in race, ethnicity data and language data into their population health program, such that they can stratify some of their quality results to a certain extent by race, ethnicity. They don't have perfect data yet, but they're working towards that. There are also different codes on claims that are used that indicate factors related to the social determinants of health, such as food scarcity, things like that, that this particular carrier are using in their population health planning and as part of their evaluation of their members' health and outreach services. So I think that's the model that we want to see everyone moving to. We need data on all of our members to be as effective as possible. And I think that is probably about 5 years out. We know the Executive Office of Health and Human Services is standardizing that data right now, which is step one. Everybody needs to be using the same definitions, and that definition needs to be shared from carriers, the providers, and the purchasers, us, GIC, and all of that is in motion. But I do want to stress that just because we don't have the data right now doesn't mean we're not setting expectations, doesn't mean we're not pushing the carriers, and we are in the RFR to reach NCQA health equity accreditation. And we are also identifying areas where we know there are health disparities, and we are looking at those areas more carefully now to improve those disparities in our population.
Thank you very much for that.
Thank you. Keep up that work, Margaret. We all appreciate it, and we're counting on you to be tough on setting the benchmark and then managing to move that needle, because we're all committed to health equity. And we just don't want it to be some fuzzy saying. So we do need to move along, Matt.
Yep.
How more slides do we have?
Yep, 2 more slides. This slide is actually kind of our wrap-up slide where we're trying to tie all this together with a sense of what we hope to accomplish through the procurement and ultimately what success will look like. So a successful procurement will be one through which we can make progress on carrier and our product portfolio, have a range of products that meet our members' needs with meaningful choice, filling some gaps, sharpening some incentives for high value care and high value plan options. We will make a commitment to a sustainable growth rate in GIC spending, ensure that it's affordable for our members and the Commonwealth's taxpayers. We've put together here a flexible approach that allows us to leverage innovation and new thinking that we expect from our carriers, really push them to innovate, hold them accountable to the strategies that they lay out for us, and have the flexibility at the GIC to adjust course where it's necessary should the plans of our carriers not help us to achieve that goal. So we want to have carriers, our vendor partners, that are fully aligned with our goals as well around health equity and behavioral health, so we can really lean into all of these priorities. So with that, I think we'll close with the last slide around next steps. Just a reminder, the RFR goes out a week from tomorrow. We will spend the spring and summer evaluating bids. We'll be back in October with our recommendations for your consideration. And just to emphasize that this really is an important step for us, but it's one step today in this multi-step process that will continue through early 2023, using the RFR, hammering out details of contractual requirements with those vendors that we choose, which is just as critical for a lot of the reasons that we've spoken about here today, then move to plan design discussions in early 2023. So it's an important step, but several more to come, and we look forward to working with you throughout the year ahead. I will just note on that last point about working with you that we have received the non-disclosure agreements signed from most of you, but there are still a few outstanding. So for those of you who haven't submitted that, for us to continue to talk to you in throughout this process in certain ways, that would be really helpful for us. So just a quick reminder on that. And with that, I will close. If there are other comments or suggestions on the procurement overview, before we move on to the executive session?
Matt, I don't see any, so I want to reiterate what I think I heard from commissioners. First of all, your team has pulled together some really thoughtful approach, listening to a wide constituency, really good engagement. So we appreciate that. We really want to drive innovation. We just don't want the same old, in the context of helping our members with cost growth, and keeping it as low as possible, but giving them the opportunity to be part of the decision. And lastly, it's all about data, data to hold our vendors accountable, data to move along our commitment to health equity. So we're going to be looking forward to getting updates. So appreciate that. With that, I want to remind you that we are going into executive session. So each commissioner is going to be asked to state that there's no other person who's in your proximity that can hear the discussion at the location where you are Zooming, unless the public body has approved the presence of that individual. So I do need a motion to go into executive session, but before that, Andrew, can you survey commissioners to confirm that there's no other person present or able to hear the discussion before we take the motion?
Sure. We'll start with you, Chair.
Aye.
Vice Chair Kaplan.
Aye.
Designee Rutter.
Aye.
Designee Butler.
Aye.
Commissioner Chapdelaine.
Aye.
Commissioner Choate.
Maybe move
Yeah.
on.
Commissioner Clenard.
Aye.
Commissioner Davis.
Aye.
Commissioner Edmonds.
Aye.
Commissioner Gentile.
Aye.
Commissioner Guerin. I'll come back. Commissioner Jennings.
Aye.
Oh, I think I heard Commissioner Guerin.
Yes.
Commissioner McEnany.
Aye.
Commissioner Murphy Rodriguez.
Aye.
And Commissioner Sullivan.
Aye.
It's an aye for me, Andrew Toby Choate.
Thank you. That's everyone.
Okay, great. So at this point, I am going to ask for a motion to move into executive session pursuant to rules and regulations. C30A 21A3, and we are going to discuss litigation strategy. We will adjourn directly from executive session. So can I have a motion, please?
So moved.
Second.
Seconded.
Okay, it sounds like all in favor. We'll do a roll call of that motion. So me, I'm aye. Go ahead, Andrew.
Vice Chair Kaplan.
Aye.
Designee Rutter.
Aye.
Designee Butler.
Aye.
Commissioner Chapdelaine.
Aye.
Commissioner Choate.
Aye.
Commissioner Clenard.
Aye.
Commissioner Davis.
Come back.
Commissioner
Aye.
Edmonds.
No, Davis is
heard her.
aye. I had to
got it.
unmute.
Commissioner Edmonds.
Aye.
Commissioner Gentile.
Aye.
Commissioner Guerin.
Aye.
Commissioner Jennings.
Aye.
Commissioner McEnany.
Aye.
Commissioner Murphy Rodriguez.
Aye.
And Commissioner Sullivan.
Aye.
Motion passes unanimously.
Okay. So let the minutes reflect that the chair is looking forward to us moving away from Zoom at some point. So let's get in-person meetings so we can avoid some of the roll calling. But at this point, we'll move into executive session. Thank you.